Senator Cassidy.
Thank you. Thank you both for being here. Mr. Chairman, thank you. Last week I was in Lafayette, Louisiana, announced our Safer Families, Healthier Communities initiative, and I just would speak to folks back home, and what I learned from them will be the basis of my questions for you. Spoke to the father of the 17-year-old, the young man who eventually died, who when he first went into treatment was asked by the insurance company to be released 2 weeks after treatment began. The fact that he died obviously indicates that this was not an effective strategy. And then I contrasted it with my next conversation, which is that if you're an impaired physician in Louisiana, there's a minimum of 3 months inpatient therapy, then 1 month follow-up before you're allowed to practice once more. So contrast that which is apparently effective, 3 months inpatient with a month of follow-up, with that which clearly was not. After 2 weeks, they were asked to leave. And then lastly, I spoke to another physician who told me of the abuse potential of our medication-assisted therapy. First, that there's a certain number of people who die from methadone overdose, and secondly, about diversion of Suboxone. So I'm going to use that and work backwards for my question. Dr. Gerard, nice to see a Louisiana guy who does well. Good to have you here.
Thank you, sir.
I know how to pronounce your name even if others don't. Let me say, as you know, there's some forms of medication-assisted treatment like buprenorphine injections and implants coming onto the market. Next-gen products are provider-administered, so they never go into the hands of the patient, therefore cannot be diverted, as I've learned that Suboxone is being diverted. Now, the law is unclear whether or not the pharmacies can dispense this medication directly to the provider, because current law says it has to go to the patient. Makes sense, you don't want the brother picking it up, but DEA has interpreted this saying, as saying that you cannot give it to the provider to then do the implant and therefore avoid the potential for diversion. Senator Bennett and I have legislation in the Health Committee that would address this problem. Can you go back to the department and see if you can get endorsement of our bill?
Certainly, I will go back to the department and discuss with the secretary. I want to state certainly that medication-assisted treatment is our best route going forward in combination with behavioral therapy to treat patients. And yes, sir, I will go back. I'm not familiar with this specific bill, but we will go back and
But we agree that there is certainly abuse potential both for the drugs used in MAT.
There is abuse potential for the drugs used in MAT. Some part of the drugs, right? So there's not so much abuse potential for naltrexone, which of course is an antagonist, but there is potential diversion and abuse potential with drugs, as you pointed out. Yes, sir.
Ms. Brandt, I'm struck. Let me ask you, I've noticed in some localities there's less prescription opioid, but there's no decrease in the number of deaths from opioid overdose, suggesting that it is illegal drugs replacing or backfilling the loss of opioid prescriptions. Is that what your data is showing?
Actually, I'm going to defer to the Admiral on that one.
Yes, the prescription opioids have been a gateway, if you will, in that 3 of 4 people who use heroin started that way, but clearly the deaths now are far overshadowed by heroin and fentanyl.
In those areas that are using MAT more extensively, are we seeing fewer deaths related to opioids?
So the data we have is that MAT is more effective than non-MAT in preventing death and providing long-term recovery. I do not have geographic data that correlates geographic use of MAT with a lowering of the death rate within that geography. I will go back.
Could you get us that?
Yes, sir. I will go back and see if that data are available. Clearly, MAT is associated with improved outcomes. So, you know, we would tend to believe that that's the case, but we need to verify that those two things go together.
I keep going back to the 17-year-old boy who was asked to be discharged and then is now dead. So something's not working. Ms. Brandt, I thought this question might be for you. It may not be. It may be for either of you. Do we have a way to track which treatment programs have better outcomes versus those which do not? if empirically I can say a physician with 3 months inpatient, then followed up by a year of follow-up as an outpatient works, but being discharged 2 weeks after being admitted and then ultimately dying maybe doesn't. Do we have best practices on this, and are we doing a proactive follow-up to see that, oh yeah, program Acme Rehab is doing really well, but Beta Rehab not so well?
Well, speaking for the CMS programs, we are starting to accumulate that type of data through our new TMSIS, our new Medicaid information system, through results of a lot of the demonstration projects we've been doing and testing of a lot of our new innovative models. We're starting to try and
Let me interrupt. Is TMSIS actually getting populated with state data? Because my understanding was that states were not as aggressively populating that as they should be.
We are actually getting states. We now have 49 states, the District of Columbia, and as of March 26, Puerto Rico, actively reporting full data into TMSIS.
That's great. Okay. I'm over time. I yield back. Thank you.